MSP and for him, because we've missed you for the last couple of weeks. But before we do that, I just want to say again, for the record here, for recording, this is the gathering of the Eagles, so to speak, the Metropolitan EMS Medical Directors Alliance from around the globe, and particularly across the United States. And yes, for those who are interested in listening to this, I hope that you'll find it interesting to sit in and listen to what we have to say here today. All right, so let's start off then with, oh, Marty's joining us. Good, thanks, Marty. We'll be coming to you in just a few minutes, okay? So thanks.
Okay.
All right, so let's start off with, let's go ahead and start with Mike Levy in Anchorage. And Mike, if you don't mind, also just give you everything report out of the National Association of EMS Physicians, for which you are the president-elect. What do you got for us?
Paul, I'd say things are pretty status quo. The biggest thing for us right now, I guess, is the focus on the January meeting. And at this point in time, we plan to have a hybrid meeting. We still plan to be there in person in Austin.
Okay.
But allowing for the fact that, of course, we won't have our whole group there. So looking at the details of assembling a hybrid meeting, I guess, is one of our foci right now. We have an executive board meeting here just right after this. I'll leave a little early for it.
Okay, good. And then thank you so much. And then the other thing I'd like to know is what is happening in Anchorage specifically. And, you know, I'd like to know two things. One is, in general, COVID attack rate. Two, what's happening with cardiac arrest there. And three, what's happening with penetrating injuries and so on. Okay.
Let's see. One, we're following national trends with increased incidence of COVID. Our mortality rate remains very low. Our ability to do testing is diminishing due to lack of, substrate. We've had some interesting things go on with the fishing industry. Most recently, I was involved in dropping a medic into a ship in Dutch Harbor, that place where they do the deadliest catch area, where 85 people of 100 turned positive on their COVID test. It's a fish processing ship. So they took all those people down to Seward, Alaska, and they're putting them on buses, and they're going to move them to an undetermined site in Anchorage for their quarantine. Okay. But again, none of those seem sick, and that seems to be more common than not in our current outbreak.
Yeah. Okay. All right. Well, thanks for the report, and good luck with all that. And you're the state medical director as well there in Alaska. Anything happening across the state beyond Anchorage?
The state stuff is, I think, again, pretty much reflects everybody else. Our biggest deal in the state, I think, is to make sure that the industries stay open that are important to the state. So fishing and mineral exploration have gotten a lot of attention to keep those people either safe or quarantined when things break out. And I think that's probably going as well as can be expected. We've had a number of isolated outbreaks, but it hasn't infected any of the villages or alike, which is a big concern based on past history of what happened during the outbreak in 1917 and the effect on native populations at that time.
Okay, got it. All right, so I see Sandy Schneider is on from the American College of Emergency Physicians, where she's the AED, Associate Executive Director, and woman of many talents. So anyways, hey, Sandy, anything to report out of ASAP or anything we need to know about?
Yeah, a couple of quickie things. Starting in August, we're going to start a new series of webinars. Actually, there'll be Zoom calls on the future of emergency medicine. And this one will be primarily looking at preparing for the next pandemic. So I will send those out to Paul and have him distribute those. Some of those may be of interest to you. They're going to be a total of 8 of them. ASEP 20 is going to all be virtual. We're not getting together. Sorry, but the registration is now open. I promise you this is not your normal Zoom call, and there will be a lot of really cool people who we have coming in virtually to entertain you and to talk with you. Our new CEO, Sue, started yesterday, and I've already spoken to her like 6 times. The poor woman probably hates my guts already. And then finally, we continue to be in very close contact with both HHS and CDC. The CDC is requesting that if anyone out there has a really good public testing program associated in some way with either your EMS system or your ED, that they'd like to know what it looks like. They're looking for best practices. So please just email me offline. Again, it's sschneider@acep.org. If your EMS group or your hospital is, or your emergency department is doing public testing, they want to know where you're doing it, how you're staffing it, and just, 2-3 sentences, not a, please. Somebody sent me like 2 pages the other day, and I was like, that's too much for me to handle.
Yeah.
But
Okay.
thank you guys for everything you're doing. And, this is becoming a really long haul.
Yeah, and it's becoming a interesting, just experience. And this group has just been so useful and keeping us ahead of the curve, especially with your input and the others and so on. And then, Marty, do you have, how are you doing in time, Marty? When do you have to get off before I switch to, I'm going to maybe get one more report because I want to get more people on the line for you.
I'm fine. I'm fine.
Okay, good. So then what I want to do next then is go get a report from what's happening with the firefighters, either at the IAFC or IFF. And Jim Augustine, you're always polite enough to be our liaison for that and give us a great report. So what's the latest on that end?
Or at both of them. So I just came off the call with the groups together.
Yeah.
We received a report that supplies are bogging down again, and that FEMA is not prioritizing fire EMS for ongoing PPE supplies. That's a huge concern for a lot of people. And so some of you may need to be aware that support for fire EMS in allocation of PPE supplies vis-a-vis hospitals, nursing homes, other congregate care facilities will be really important. Second, as all of us have shared, and testing has really slowed down to a crawl in many places, and it's making it difficult to get people back to work if they have a test-based strategy. The CDC came out with a new guidance yesterday, which I'm still working through, that everybody ought to know about in terms of return to work safely. It is moving away from test-based strategies. And I really believe all of us need to be aware of where testing is in our communities. I worked the weekend, and in the ED, we have patients who were testing, and we tell them we have no idea when your test is going to come back, because that's how slow the process has become. Again, supposedly an issue related to reagent availability, and of our machines hitting their limits, and sometimes their maintenance limits, et cetera. We're growing problems with disinfectants in our vehicles and in our stations, and OSHA hasn't come up with word yet on the balance between throwing disinfectants everywhere and the health of the members. And by the way, the surfaces that we're throwing bleach and alcohol and other products on. So just be aware of that locally. And then finally, it was good news about vaccine development over the last couple of days. And we're certainly hoping that will move forward. Those are the big issues on the minds of IFC, IFF. On the ED side, I want you to be aware, we just published ED volume decreases for the months of this year in the United States. For March, volumes were down 18%, April 48%, May 42%. In June, we were at a 21% volume reduction. So that was across over 2,000 emergency departments in the country that we're surveying. It probably matches some of your EMS data, although EMS has not been hit quite as hard percentage-wise. But those are probably numbers that you can keep in your head for your emergency departments. And I think we're going to be at a permanent 10% decrease compared to historic. Paul, that's it. Thank you.
You're very welcome. So what I'd like to do next is, I think we don't need any more organizational reports, just want to get down to the individual thing. And one of the cool parts about this webinar has always been the educational thing, keeping people a few weeks ahead of everybody else. And I got one special case today that I want to do. So we're very privileged to have today is the principal investigator of the recent NIH trial. It's a little bit more than that, probably less so. But anyways, a trial in which we are looking at TXA in TBI, in this case, severe to moderate TBI. And the person who is the principal investigator looking at TXA, and he'll explain that to you in a little bit more detail, is Dr. Marty Schreiber. Not only married to a wonderful woman named Karen, but he is the professor and chief of trauma, critical care, and acute care at the Oregon Health Sciences Center and Oregon Health and Science University. And he has been there for quite a while and been running a great show there and done some really terrific work in the area of coagulation and so on. I could go on forever. He's been doing great stuff, has a great laboratory service there and so on. But in any event, he has just gotten great word in press, in JAMA, to come out on August 18th, is the article about TXA and TBI, which is profound. I just want to say up front, it's JAMA is very nervous, of course, about any kind of, there's an embargo on this. It cannot be going out. So anything we say here today is kind of a quality assurance thing. Keep it to yourself. I'll leave it up to him to put out whatever he feels comfortable in putting out to you. But I think it's really amazing work, and just congratulate him for his work, also for his service to our country in the past as part of the United States Army Reserve. So with that, hey Marty, can you want to come on and welcome to the show? Okay, welcome to back to the show that never ends. All right, I'll see you. All right.
Yeah, thanks, Paul. It's great to be here this morning with all of you. I work very closely with John Jew, who you see on the call, and a lot of this pre-hospital research that we do couldn't be done without him. So thanks, John, to you. So I'm going to just kind of briefly tell you about the study that we performed. It was through the Resuscitation Outcomes Consortium, and it was actually the last major study of the ROC. But this study was primarily funded actually by the Department of Defense.
Yep.
And then sort of executed through the ROC, which does have, and I did have NIH support, as well as similar institutions in Canada and American Heart Association.
And Marty, should interrupt you. I just wanted to give you a heads up that John Holcomb has just joined us as well. So that'd be very
cool.
Cool.
Excellent.
Give him a good introduction when you're finished. Okay, thanks.
So we performed a prospective randomized pre-hospital trial in patients with traumatic brain injury defined as GCS 3 through 12. The study was performed throughout North America to include multiple sites in the United States and Canada. And basically, we ended up enrolling about 963 patients in this trial in North America. The intervention was 3 groups. Patients were randomized to receive either placebo, 1 gram TXA pre-hospital bolus followed by 1 gram over 8 hours in hospital, or 2 grams pre-hospital followed by a placebo infusion in hospital. The inclusion criteria were GCS, traumatic brain injury mechanism with a GCS between 3 and 12, in the absence of hypotension as defined by GCS, systolic blood pressure less than 90. So we were looking for patients with isolated traumatic brain injury, moderate to severe TBI. The randomization occurred by site, and EMS agencies carried kits, blinded kits that were identified by a code. And essentially, the intervention came in a 20 cc vial, which was attached to a 250 cc bag of normal saline. The vial was emptied into the bag of normal saline, and then the solution was to be infused over 20 minutes. Obviously, in this pre-hospital trial, nobody was counting minutes or anything, and it went in at variable time periods, some much faster, maybe some even slower. The infusion may have been completed entirely pre-hospital, or could have been ongoing in the hospital, after which the in-hospital infusion was exchanged and started. We had set criteria for stopping the infusion if the patient developed a seizure, got CPR, was found to have renal failure, or several other things. We stopped the infusion either in hospital or pre-hospital. We were incredibly successful actually at identifying the correct population. and following the protocol. The compliance with the protocol exceeded 95% overall, which was, just really, we were shocked, and up to 98% compliance with the protocol in the pre-hospital trial.
Yeah.
So essentially that was how the study was done. As I said, we enrolled 963 patients in these three groups. The primary predetermined endpoint of the study was Glasgow Outcome Score Extended at 6 months. So a late outcome in all patients. We actually, in the primary outcome, were combining the two TXA groups. So that outcome actually turned out to be negative. There were trends toward improved outcome in the 2 gram group, but that was not statistically significant. The major predetermined secondary outcome, however, analyzed specifically those patients with intracranial hemorrhage. And in the group of patients with intracranial hemorrhage, which was 56% of the population. So remember, these patients were being identified pre-hospital. There's a number of reasons why you might have a low GCS, and 56% of them actually had a lesion on the CT. In that pre-identified population, there was a significant improvement in survival of about 12%, 28% versus 16% in the group that received 2 grams. The groups that received 1 gram of placebo were identical essentially in all findings. There was absolutely no benefit at all with the 1 gram treatment group. So improvement in survival of 12%. And interestingly, almost all of the difference in the survival occurred in the first 10 hours after admission. The patients received their drug an average of 42 minutes after injury. So this was a very rapid infusion done very quickly, which we think is critical. So large dose early after injury resulted in improved survival, and also statistically significant disability rating score, which is another long-term outcome, neurologic outcome, improved outcome with DRS as well in the group with intracranial hemorrhage. In terms of complications, there was an statistically significant increased rate of seizure in the patients who got 2 grams, and that rate was 5% versus 2%. We looked specifically at those patients, and they had no difference in their long-term outcomes. So there did not appear to be any bad outcome associated with having the seizure. We defined a seizure, which is very difficult in this kind of study, as observed seizure-like activity that required treatment by the EMS personnel. So they gave a benzo to treat what they thought was a seizure. That's how we define it. Did those patients all have seizures? We don't know. But the rate was 5% versus 2% in the other 2 groups. There was no difference in thromboembolic complications, DVT, PE, stroke, or MI in the groups. So essentially, those are our findings. They're going to come out in JAMA August 18th, as Paul stated. And I'd be happy to answer. One other point I'd like to make is we looked at the 44% of patients who did not have intracranial hemorrhage, which is sort of, in a sense, it's like a control group. And those patients had no difference in outcomes whatsoever, either good or bad, in the groups. So giving the 2 grams TXA to essentially what appeared to be more or less uninjured patients did not seem to be harmful, which is very important if you're going to give this pre-hospital. So that sort of summarizes everything, and I'd be happy to answer any questions. And if John, you want to add anything, happy for that as well.
And before John comes on and we take any questions, I wanted to take the liberty of just kind of doing a quick recap on what you were saying, which is, and emphasize from my point of view, and largely this is stuff that John Holcomb will probably reiterate to some extent. But one thing is that versus CRASH 3, where they're looking like more mild to moderate head injury, this is severe head injury. This is moderate to severe in this case. And that's identified by the fact that, traditionally it's always been about 40% of people with a Glasgow less than 8 will have, a space occupying lesion called blood. And in this case, 56%. This was a sicky group. Okay, and then that brings up, so that's where it may have, the fact that it had impact here is just really important. Secondly, you want to reiterate what he said. You had a built-in safety group here with the control group, the 44% without the bleed and having not a lot of complications. Again, that's really, and then the other thing, physiologically, to me, it didn't make sense to be giving 1 gram plus 1 gram, except we were following what CRASH 2 had done to compare that. And this became important because it showed it didn't make that much difference in the head injury, where the 2 grams up front, which makes more physiological sense, getting it done early was just really very important. So thank you for all this great work. So John, you a lot of this stuff that I just said came out from you. And do you have any other things to add to this?
Probably 3 things. Number 1, I think this is completely doable for North American EMS systems. Our crews got much better in measuring the Glasgow coma score. We say this tongue in cheek as a, well, what's his score? Where did you take his points off? So we had to put poster boards on it. Number 2, almost all the cases, we actually were able to establish IV and administer the bolus very, very quickly. Number 3, I think our response times are fairly quick in Multnomah County. They're about 8 minutes, 90% of the time. And so I think this is sort of exhibits rapid response and early identification. And number 4, the drug is inexpensive and doesn't need to be stored in any special fashion. Inexpensive being probably less than $100 for 2 grams. It comes in 10 ml vials at 100 milligrams per ml as well. But everything else Marty said applies. And finally, this matches in part. I'd be interested to see what Marty and John Holcomb say about how it matches with CRASH 3. I was personally surprised about the 2 gram bolus.
Yeah. Well, I take exception to that because I was surprised. I think this is the way to go. So for the reasons I've always stated, because if you're going to have problems with it, it usually is laid on. If you take CRASH 2 at face value. So I want to move on to John Holcomb. Dr. John Holcomb, as all of you know, you've met him before at our Eagles meetings, and he was a former professor and vice chair at for the Department of Surgery at UT Houston, now currently with the Department of Surgery at University of Alabama in Birmingham, but more importantly, led all the research efforts during the Middle East crises and conflicts, and brought back things like us bringing plasma to the streets, like the tourniquets and so on. And he's been just a real terrific person who's led here. And John, you'll have some more insights here, I think, to talk about a couple of things if you wouldn't mind address, like, will this eventually be applicable to all trauma patients, et cetera? And also, has this already had an impact at what's happening with, like, for example, the Army or your own local area? How are we doing there? So with that, please turn it over. And John Holcomb, please welcome Colonel Holcomb.
Thanks, Paul. Marty, great overview of that, your study. And I think this study is going to be a landmark study in trauma. It's the first study that's ever shown an improvement in, as Paul said, moderate to severe TBI. And the improvement was not in the order of 1.8% like most of the CRASH studies. It's 12%. Huge difference in the patients with intracranial bleeding, which of course is the target population. As you all know, all of the studies that have started pre-hospital, pre-CT have a 50 to 60% change in our non-patient. You enroll 40 to 60% of the patients don't have intracranial bleeding because of the difficulties of identifying the patient pre-hospital, and Marty studied it better than that. So I think it's practice changing. And the reason I say that is because the data that Marty's presented already. Marty, at the end, maybe you can talk about the TEG values as well. People are asking questions about TEG in this study. You have those data. I would say that at UAB, where I practice my clinical and research efforts now, we've changed our protocol to 2 grams for head and hemorrhage. The U.S. military, not just the Army, but the military through the Tactical Combat Casualty Care has changed their protocols as well to 2 grams, going from the 1 and 1 to 2 grams for heads and hemorrhage. So, and as Paul suggested, it never made sense to us to do the 1 gram and then follow another gram over 8 hours. All the action occurs in the first couple hours in these patients, either live or die one way or the other. And why would you continue to give a drug after the bleeding has stopped? Didn't make much sense. And Marty's data supports that in head injured patients as well. So Practice changing, easy to do, cheap, very doable by IV or IO pre-hospital. And we've changed our practice at UAB, and the DoD has changed their practice already based upon these data.
So John, a couple of questions have come up. We'll go back to the TEG in just a second. In fact, I was talking to surgeons yesterday, and they were bringing up the thing that your own studies had shown that that you had problems with it, or that didn't work out in some of the studies that you had done. Can you tell us a little bit about why this study is different and why you've changed your practice now? Give us a little background on that, and then secondly, address the issues with TEG, because people say they don't like it because it messes up the TEG supposedly, anyways. So if you can address those two issues, so your own studies, and then the TEG issue.
Well, I think the summary of our studies in TEG going back now over a decade is that it's faster, cheaper, and better than conventional coagulation test, and that's true. So. And as most coagulation things, if you'll remember back to medical school and the cascade, if you will,
yeah,
it's a little complicated. I think you can, just like anything else, combine the TEG values with your clinical gestalt and taking care of these patients. Those are important. I would say that we are learning more and more about the LY30, LY60, the fibrinolytic part of the TEG pathway. I think the knowledge started on the left-hand side and is moving to the right, if you will. And
yeah.
Our knowledge of how to use those numbers. And so the fibrinolysis part is catching up. I think we threw out D-dimer with the baby bathwater a couple years ago, and we're bringing back D-dimers in trauma patients and understanding how to dilute those D-dimers and the subtleties of fibrinolysis in these trauma patients. Without going into greater detail, we utilize TXA often and frequently and do TEGs, and we're not concerned about the effect on the LY30. Marty, I know what you're going to say here. You want to elaborate on the fibrinolytic TEG portion?
Yeah, so John knows the answer, but we looked at TEGs in these patients on admission to the hospital, and much to our surprise, there was zero difference between patients who got any of the three groups. Absolutely no difference in the numbers. And we also broke it down by fibrinolysis shutdown physiologic and hyperfibrinolysis. Exactly the same numbers in all of them. The TXA given pre-hospital had zero effect on the TEG. So I think that's very important. Now, to address the issue of using the TEG to decide whether or not to give TXA, I think that's a huge mistake, because that means that your patient has to be in the hospital, have the TEG drawn, and then you have to wait for the LY30. So our benefit was shown when the drug was started at 42 minutes. That was in pre-hospital environment. Now you're waiting for the patient to get to the hospital, have the blood drawn, have the TEG started, and get to LY30. You're going to be looking at giving the drug at 2 hours. And by then you may lose the benefit. So I do not think that is a good idea at all.
Can I make another comment on that?
Yeah.
Yeah, so I think that, I agree with everything Marty just said. Totally 100% agree, which for those you all know, Marty and I, that's a little unusual, but that's okay. By the way, the picture behind me, we were together fishing in Pensacola, Florida when we took this picture a week ago. So the way we started using TEG and TXA a decade ago, right, is kind of waiting to get a fibrinolytic signal before giving an antifibrinolytic drug. I thought that was reasonable a decade ago. Well, we've learned stuff. We've learned stuff since then, and we continue to learn. There wasn't a great safety data signal in the CRASH 2 because they didn't really look for it. Now we have a lot more safety data with this drug. It is safe. It does not increase complications. Those things were really unknown a decade ago, and now we know a lot more. So that's why in my practice and in others, I think you're seeing a lot more use of TXA now than a decade ago and a lot earlier.
Yeah, and then so Marty, just let's get back to the key points here. I absolutely agree, and it's always been my mantra: the earlier the intervention, the better results. And as we talked about on the previously, it's when you talk about something being good or bad, it's how you use it, when you use it, and this is a classic example of that, in my opinion. So the question is, you said it was 42 minutes. Was that a mean, or was it a percentile of the group, or the 42 minutes?
That's 42 minutes median time.
Median. Okay, got it.
Yeah, with small confidence intervals.
Okay.
From injury, right? From injury, Marty.
From injury.
Yeah. Do you have an idea what would have been the 90th percentile on that by any chance, or you can look that up?
I'd have to go back and look at the data.
That'd
Yeah,
be
I don't know offhand, but the conference intervals are small.
Yeah, good. And it goes back to the whole thing, like get it done within the first hour. If not, it's just, we're finally getting to a golden hour for once, because I always thought it had to be shorter than that. Hey, so that's really helpful and interesting. And then the other interesting thing was this is a good question Chris Colwell brought up from San Francisco, which is was there anything you could pick up in difference in terms of the people who got better with the TXA versus the ones that didn't get better in your head injury group with the bleed? So in other words, were there TEG differences when they got in, like it didn't respond to it, I guess is a way of implying they're inferring from that question.
Well, definitely not based on the TEG. And so I think the problem with trying to figure that out is figuring out why did the people who died. So we were preventing death. We saw a prevention of death and the patient got TXA.
Yeah.
So the question is, why did, in those first 10 hours, why were the patients who didn't get 2 grams of TXA dying? And the answer was they were herniating. So they were primarily dying from cerebral edema and herniation. We didn't see differences in the intracranial bleeds in the 3 groups. So we are hypothesizing that the primary mechanism of action of TXA has to do with sealing the endothelium through a plasmin-based mechanism. And that's a source of something we're going to look at with the NIH. One other point I want to make that I think is important is that when you do a TEG, when you're using the TEG, you are only looking at that split second of time when the blood was drawn.
Good point.
So when you look at D-dimers and pi1s and TATs and all these other things, those things have 6 to 12 hour half-lives. So when, if you have a brain injury and you become fibrinolytic in the field, the D-dimers from that injury are going to show up on your admission labs. But that fibrinolysis may not be occurring anymore by the time you get to the hospital, and that may not show up on the TEG. So
yes,
those are differences. You can call them benefits and disadvantages of the tests, but a TEG only tells you that split second when you drew it. And this is a dynamic process. So I think that's interesting, and people should just be aware of that.
Yeah. So I think if I saw before, I think I saw Randy Katz was on there before, but you guys have been using TEG for COVID, which is really interesting. But what's interesting is that when the trauma surgeons know this better than us, but when you follow them sequentially, there's almost like could be a diurnal variation in them. And I like your idea that the snapshot doesn't capture it all right there, Marty. I think you're right.
Right.
So, hey, anything else to add to that, though, Randy, while you have it on? Because you guys use it pretty well there, because Randy Katz from Hollywood, Florida at Memorial Health System there, the trauma center there.
No, I agree. I mean, it's a snapshot in time, and we've seen this with COVID-19 patients. Patients go from hypocoagulable to hypercoagulable depending on the severity of disease and the timing of the testing. So I agree 100%. It's a snapshot of time, and you have to take that into consideration when making treatment decisions.
Yeah. Okay, good. All right. So that's been very, very interesting. And thanks a lot for all the great information that both of you gave us. While I have you both on the phone, we've talked about this previous, one thing that's going on, and Randy, you could have confirmed this, that in your shop, for example, Randy works down there with Drew Rosenthal that you guys know. And they're seeing a really big increase in penetrated injuries, right, Randy?
Yeah, so you're talking about trauma volume in general?
Yes. Yeah.
Yeah, I mean, I don't know what percent it is. It's definitely increased, particularly the past month. We've seen a significant increase towards the end of June and July. In addition to trauma, mental health volume has been.
Okay. Well, then let me do this. I'm going to go ahead and pitch it back to John Holcomb because he's been looking at this and keeping track of this on a national level. And AJ Heitman, if you could turn off your noise there because we're picking up on that, I think. Okay, but go ahead. Can you go ahead with that, John? Report on that.
Yeah, you know, the center, it's interesting. I think early on, and Marty can comment from the Portland area, but early on, I think all trauma centers saw a marked decrease in admissions for the first couple of weeks or maybe the month, you know, with motor vehicle crashes going way down. And then at least on the WhatsApp chat thing across kind of acute care surgeons trauma group that's going, everybody saw a big increase in the percentage of penetrating trauma, kind of linked to what everybody thought was people staying at home, getting angry with each other, kind of around what we see around Thanksgiving and Christmas every year.
Yeah.
You know, and now if you look and listen to folks across the country and at our center as well, there's an increase in the trauma admissions. You know, the absolute number increase in trauma admissions with a coexisting sustained increase in the percentage of penetrating traumas going on. So my guess is that's going to be very regional based upon what's going on with shutdown with businesses and bars and opening, et cetera.
Well, that's something we might be able to track. So just like we did with the I hate to be painful to everybody else, but just like we did for cardiac arrest study, I think if you simply look for something like penetrant injury, because that's the major thing you're seeing. Are you seeing an increase in blunt trauma as well?
Yeah, blunt traumas are back up. So absolutely, you know, there's numerators and denominators here, Paul.
Yeah.
And you got to be a little careful with it, right? So the absolute number of admissions now is greater than it was the same month last year, right? You got the month-to-month variation that goes on. And I think what will be interesting is when schools don't open or do open, and you know, it's anyway. We got to keep in mind numerators and denominators.
Okay, and then when you say numerators and denominators, what is the denominator you're talking about then?
Well, all admissions, all trauma admissions.
Okay, got it. So, I mean, I think we can collect the data at the very least, get some raw information. When we got the raw information about cardiac arrest, it was profound. It really was, and it really did go along with the attack rate in that community versus people staying at home and having their heart attack. And so we'll have to think about those concepts and what you just said about when they reopened and so on. Maybe that goes along with it. But if everybody agrees, I'll put out a survey. We can maybe look at that. I think that's going to be another interesting and true collateral damage of the epidemic. And so very interesting stuff. So thanks for letting us know about that. And then you got the information out. I think someone asked a question about the August 18th is a print journal. Is there going to be any electronic version out before that, as far as you know, Marty, on the article on August 18th in JAMA?
They did not mention that.
Yeah.
They did a pre-electronic version.
Okay, got it. Okay, good. Well, anyways, congratulations again, because I think John's right. It is a landmark paper, and I think this is going to be, you know, really, really, really interesting to see how that's going to react out there. One thing I would
Paul, let me just say one other thing. So JAMA is entirely focused on the primary outcome.
Yeah.
You got to don't just read the abstract, because if you read the abstract, it's going to be a negative study. You got to go to the last two paragraphs of the results section.
Right.
In a tiny little section in the table that shows all the important results.
Yeah. Yeah.
Paul, if I can, this is why this conversation is really important, right? The
Yes.
data are there. This was a pre-planned analysis.
Exactly.
And as you and I have talked about, publishing in JAMA is heinously painful.
Yes.
It's worthwhile, but it's painful. And this is practice-changing information that is cheap and easier than what we're currently doing, right? So that doesn't happen very often.
Yes. Yeah. And I think I've been there before with JAMA within the last year as well. And the interesting thing at the end, then they start putting, not only do you get past the reviewers, and it's actually not too bad, you know, and then you get into their local you know, editorial staff who are not necessarily clinical, they're not medical per se, and it gets to be very, very interesting from that point of view. So I think this is, you're right, this was great to have this forum. And that's one of the reasons why I elected to have the forum, you know, so we can talk about it. Now, having said that, we've got a couple of media folks on today, such as AJ and Hillary. And so this is embargoed, so it really can't get out anywhere, either electronically or, in print, et cetera. And so please be respectful of that. Having said that, I'm sure that John and Marty would be very, very glad to talk to you in the interim so you can have something prepped and ready to go when this thing does come out, right? You agree with that, John and Marty? You okay with that?
Marty.
Yeah. Let me just add one last thing. So our focus right now is IM injection. So we've applied for some studies with the DoD to see if we get the same organ protection IM as we do IV.
Huh.
John, you mentioned earlier, the maximum concentration that can be achieved is 100 milligrams per cc. So this is 4 or 5 cc injections to get to 2 grams, unless we can figure out a way to concentrate it further. But we're thinking about, this could be buddy aid or self aid in theater.
Yes.
And, if we can get this IM, if we see the same effects IM as IV, ultimately this could become an IM injection for self and buddy aid in theater.
Or we could
Marty, today it's IV and IO, right?
Correct.
And the other thing, we used to always use it early on for nosebleeds, so maybe we could do an intranasal version.
Oh, no, that's happening already. Topical TXA that's a thing.
Yeah, I know. So
Absolutely.
that's what I'm saying. Maybe that's why it gets closer to the brain, right? Well, anyways, so listen, so there's a couple of people here on the line that you may hear from. One is AJ Heitman, who is at the Journal of Emergency Medical Services. They go out to a large audience, and same thing with EMS World with the editor there, Hillary Gates is on the line here. So if you hear from those guys, you'll know what it's about, and that'd be great because we can get, they'll promise to embargo before the, up until the thing, then that way they can get it out early. And this will go out to a lot of EMS personnel around the world, et cetera. Okay?
And I can't speak for Hillary, but I can say on behalf of GEMS, something that's written up rather generic and concise for the pre-hospital audience. I could push out if it comes almost like a news release. And I don't care if it's the same thing that you send to Hillary, as long as it's some kind of a standard format, because it's important enough information that it's not exclusivity, it's distribution.
Okay.
Great, thank you.
So while we have you guys there, I wanted to make sure we got that clarified because I want to protect you also from the the angst of JAMA. So anyways, the next thing, I just want to know if the audience in general had any other questions. It looks like we've had a good chat line and asking questions there. Any other questions coming up or any other concerns or comments from the group? Okay, hearing none, we'll go ahead and proceed on with the rest of the thing. You guys are welcome to stay on board and hear what happens. Why don't I just, in terms of reports, I want to hear from a couple people that are on the line here, such as Ken Shepke, who's the medical director, state medical director for in Florida, as well as our medical director from West Palm Beach, our EMS Eagle there. Okay, so go ahead, Ken. What's going on in Florida?
Good afternoon, everyone. First, I just well, that's one of the things I want to talk about. I want to thank Marty and John. That was absolutely fantastic and really relevant to the world of EMS. I really appreciate you guys spending time with us and giving us that knowledge. So Florida, we are hopeful that our status as the center for the country may be a time-limited event. We've been tracking our numbers, obviously daily and in detail, and our transmission. Our relative transmission rate has been slowly decreasing. We're now at 1.0 for our RT, and that suggests that if people continue to behave and wear their masks and do all the mitigation methods that we're asking them to do, that we should see our cases level off. That's what we're hopeful, and we're still hoping that we're going to get that number below 1. We can start seeing a decrease. So we are now at 369,000 cases in the state of Florida with a case fatality rate of 1.4%. And we've got a hospitalization rate of about 5.7% across all those cases that I just mentioned. 9.3 thousand new cases today. So we are still ramping up. We've got about 10,000 folks in hospitals across the state. But again, the silver lining here is we're hoping that we're going to see a leveling off now that we see that our RT is down to 1.0. So that's the big news for us.
Okay, That's great. That's tip of the iceberg stuff. And not, I mean, I should say canary in the coal mine going the other direction. So that's great. Okay, good. All right. And anything else to report from there? And then what's your, one of the things we've looked at, Ken, you and I have looked at giving 2 grams of TXA to our hemorrhaging patients as part of our routine with the whole blood, transfusion in the field. But we got pushback in the trauma center area. So I hope this is going to be very helpful, et cetera, because you were already ready to do this up front, right?
Yeah, I actually met with my folks in Palm Beach County, and they're absolutely, totally in favor of getting whole blood out in the field. And we actually, we talked a lot about TXA. We were getting ready to put that out in the field as well. And then it was felt that it was, it just wasn't clear yet who I guess phenotypically, they were talking about tags, and they were talking, that's when I got introduced to tags. This is a couple of years ago now, and the trauma surgeons weren't quite sure whether TXA would help or hurt, depending on phenotypically how you respond to trauma, whether you become hypo or hypercoagulable, et cetera.
Yeah.
So this work is very, very helpful for us to guide us.
So 2 things. Again, I want to reiterate what I said, that what's really good about this is this study has gone from the crash 3 to a moderate to severe injury group, number 1, has a built-in safety cohort there, as John and Marty have emphasized, in which there weren't additional complications. And that's so cool because it's so important because it was done early. I think a lot of the complications occur later, but for the people who survive, because if you don't have control of bleeding that early on, then it's just doesn't make sense then to give it later. So that's why this was important. And then finally, I think that just the whole concept that it's physiologically makes more sense to do it upfront early, and that's it. Now, the question I have for John coming back to this is, how do we argue with them the extrapolation from the head injury study to the general hemorrhage, as you've done not only with the armed forces, but also at your own shop? How do we argue with, not actually argue, how do we persuade them? What's the language there? What's the data we have to support that? Or is it just inference?
So it's a great question, Paul. And to my knowledge, there's not great hemorrhage only data with 2 grams.
Yeah.
Marty, I think that's still correct. Is that right?
Yes, that's correct.
Yeah. So that's a little bit of a data-free zone. There are a lot of patients who have both, especially civilian blunt, who have combined blunt and truncal hemorrhage. The data is very clear on giving TXA early in both populations. The question is the dose. And honestly, as we discuss this in the TC3 committee and have a paper that will come out in the Journal of Special Operations Medicine that specifically addresses this exact question, it kind of came down to convenience, diagnostic ability pre-hospital, ease of use by the medics. You didn't want to have the medics with multiple doses.
Yes.
And the combined blunt head and truncal hemorrhage question, which is very common. So the answer is, we opted to give 2 grams, at the same time recommending that the 2-gram hemorrhagic shock study needs to be done.
So I want to add something there. So people might wonder, why 1 gram, 1 gram? Where does that come from? Well, it turns out that TXA has been used forever, for decades, but the primary utilizations were for primarily elective surgery, things like cardiac surgery, spine surgery, orthopedic surgery, where the insult is like ongoing over hours.
Yes.
This has nothing to do with trauma. Trauma, you have a single insult and, you're either having a brain injury or you're bleeding. This is not elective surgery, but the 1 gram is coming from the elective surgery world. So, yes, there is no data that 2 grams is better than 1 gram in trauma or hemorrhagic shock, but there is also no data that 1 gram is better than 2 grams.
That's the reason we opted for the 2 grams. So, by the way, I would just say, when Marty operates on trauma patients, it's a secondary insult.
That's great. You guys are definitely part of the Eagles. This is cool. So I love it.
Yeah, but John's patients are always pale after his operations.
Wonder why that is. Hey, so actually, if I don't know if we're beating a dead horse too much talking about this TXA thing, but I also like John to bring up, and then Marty, you can add some commentary too, is that we actually don't know very well about how TXA works. It could actually be anti-inflammatory improper. It's not maybe all, a clotting diathesis tool. So you want to comment on that?
Yeah, it's interesting when you dissect out these papers, the early papers to include both the civilian and military papers, there's very little change in the transfusion amount in the studies. And so many of us, Marty and I and others, were asking this question, well, how does this drug work, right? And both of us worked pretty extensively on endothelial biology, kind of from a basic science point of view, and permeability, edema formation, both insult on the glycocalyx and the endothelium, and then repair by using blood products. Marty said this in passing earlier, and I completely agree. I think that the main effect of this drug is going to be, in the trauma situation, going to be on repairing the endothelium.
Yeah.
In the elective surgery area, it's very clear that in large volume cases, elective surgery, when it's given pre-insult, pre-elective surgery, it does decrease blood loss. But anyway, it's going to be interesting to tease out the mechanistic data.
Yeah, is there any indication that it does work or repair or help with the glycocalyx, for example, just as we said with fresh frozen plasma?
Yeah, there's some data from Rosemary Kozar's group on the epithelial side. Marty will have the data in a sub-study that I'm sure will come out, and he can talk some more about that. Marty, have you guys analyzed those data yet?
No, not yet, but there are existing data showing that plasmin is directly related to endothelial permeability. And that's obviously one of the mechanisms that TXA works by, is preventing the breakdown of plasminogen to plasmin. So the hypothesis is that this is related to a reduction in plasmin production that results in decreased endothelial permeability. Just out of interest, I didn't mention this earlier, but we did see decreased blood transfusions in the 2-gram TXA group. No difference, 1 gram versus placebo, but there were less blood transfusions given in the 2-gram group. We looked at lesion size. We analyzed lesion size in this study. We did not see a difference in the changes in lesion size in patients who got more than 1 CT. Interestingly, but remember that you lose all the patients that die. So there's a survival bias here.
Yeah.
So that has to be considered. So many of the parameters we looked at are affected by survival bias, but that was one of them. We didn't see a difference in the change in lesion size.
Okay. Hey,
in the patients who survive long enough to get a second CAT scan, right?
Yep.
Yeah.
Exactly.
And if we've got, of course, we got Professor Fumagalli from Milano on the line with us. I want to move over to him in just a couple of minutes, Roberto, but I do want to take an additional position here. Chris Colwell, who is our Eagle in San Francisco, was the Eagle in Detroit, working very closely with Jin Moore. And did you guys do a TXA study at that time anywhere there, and how did that turn out? And how do you, let's say, delineate or reconcile what we're hearing here today? Chris, are you still there? Sorry if I lost you. Hey, Chris Colwell, you there? You just sent a message. That's why it's interesting. So I hope he's still there. It looks like he's there. It looks like you're still muted, Chris. He may be distracted by something else that was going on there. But hey, Chris, if you hear us, get on. So I'll wait for that. But that might be interesting because I want to see. Because here goes. He's going Chris Colwell to everyone. Says, Marty, any idea what the Dutch data on TXA is going to show? But Chris, can you get on the line with us? I don't know if you can hear us or not. All right. Well, anyways, Marty, you want to address that one then? Do you know anything about the Dutch data on TXA?
I haven't heard anything yet.
Okay, got it. Okay. Well, Chris, if you get on sometime or if you wake up, let us know. Okay, I think he's there, but I just, obviously because he's writing messages to us right now. All right. Well, let's go ahead then to Milano and hear from Professor Fumagalli. What's the latest there? Are you guys still in good shape, or is it getting bad again, or what's happening now you've kind of started to reopen there?
Situation right now is quite, let's say, quiet, really. Let's say that the last week we admitted to the hospital, let's say to our hospital, no more than 20 patients, but they were really not really so sick, no ICU admissions at all. So up to now, today, we have 12 patients in the hospital. 4 are waiting for surgery, so they are positive, but with no symptoms at all. And all the others are just having mild symptoms. So actually, and this is situation all over Lombardy. We got in touch this morning with all the other ICUs, and basically the patients in the ICUs overall are 20 in all the Lombardy. So up 8 million inhabitants, we have 20 patients inside the ICU for COVID-19 problems.
Okay, got it. Hey, so anyways, I just wanted to say is just thank you again for this morning. Congratulations. I think that's looking good. I won't tell anybody yet until we get the final word, but that was very promising information we got this morning. So thanks I got your email. Thank you. One question I did have for, I think for Lauren Maloney, I don't think she's on. She just wanted to confirm that your jurisdiction has about 4.2 million people when you look at your cardiac.
Yeah, exactly.
Okay, that's what I told her from our data that we had. Okay, so thank you so much. Anything else you want to know from us? We were just talking about TXA. There's going to be a study that's going to come out in the Journal of American Medical Association, and some of the lead investigators, including the principal investigator, is on the line with us. And it's what he's reporting is that 2 grams given early on, the median was within 42 minutes for severe head injury, was having significant increases in survival rates compared to the ones who did not get it. And they had people with more than crash 3. They had people who were severely injured, severe to moderate injury. 56% had some blood in the brain on the finding. But the other thing is that the other 44% who didn't have the bleeding in the head didn't have any further complications, so there was a built-in safety group. So a good study. We're not announcing that yet, but we're letting everybody know that it's coming out on August 18th and to look for it because we think it's going to be a groundbreaking story, okay? So that was, I'm glad you got on board with us. Thank you. I know you're so busy there. It's great to see it too. So by the way, he's always had the distinction of being the best dressed eagle. So I just want everybody to know that. So let's move on. Chris Colwell, I think you've joined us from San Francisco. Chris was in Denver, and Gene Moore has done studies on both looking at fresh frozen plasma, or I think TXA as well in trauma cases. Can you tell us a little bit about that?
Yeah, actually, we did not use the TXA in the pre-hospital setting. We have average transport times of about 6 minutes, and so we did not have TXA in the pre-hospital setting, but we did have plasma, and found particularly in terms of the sicker patients some benefits with the pre-hospital fresh frozen plasma, but no, the TXA was not part of that study.
Okay, that's what I know, because that question was asked of me yesterday by some other surgeons, and I was not aware of that, so I wanted to double check that. So it sounds like this is straightforward. That is interesting that I told them, I said, well, if it didn't make any difference, I have not heard of that study. I said, it's because they have very short transport times, and you won't be able to detect much of a difference. So, and that's
and we're running into a similar thing in San Francisco, where the transport times are averaging about 6 minutes and 20 seconds. So that has limited somewhat of our use. Sorry about the distractions. We're having a fairly significant protest going outside San Francisco General right now, so there's a lot of screaming in the background. I will mute.
Are they? Well, it's okay. No, we can hear it, and that's kind of makes it fun. Tell us what's going on. What's the protest about, and why are they at the hospital?
Well, all right. If you guys have a second, it's kind of an interesting story. We had a patient who has some real behavioral health challenges, and particularly with sexual expression. He was out in the ambulance bay expressing himself. We had him, law enforcement got involved, which has now triggered a protest on law enforcement involvement in patients. And so we're seeing both behavioral health kind of out of control and a protest on law enforcement intervention of that behavioral health issue.
Got it. Okay. Very interesting.
Sorry about the screaming.
No, it's okay. We like it. And it's great ambiance, especially with the full moon behind you, right? So thanks, Chris. Anything else going on in San Francisco in general? Are you guys still kind of under control, or is it getting busier?
We are. We're getting busier, but we still have ICU beds that are open. Our wards are filling up, but our ICU rates are actually lower than they were in April in terms of overall numbers. So we're doing okay from the intensive care unit standpoint on this point. We're still seeing about a 1% to 2% increase in positive tests every day, and yeah, our EMS volumes remain about 15% lower than normal.
And it's a younger generation as well that's coming in, right? Because I think a lot of the older people are staying home. Is that what you're seeing there as well?
Yeah, about 80% of our positive tests are in patients 40 years old or less.
Yeah. Roberto, over in Milano, thank you a bunch, Chris. That's great. And then are you seeing the same thing, that your cases are more the younger population, Roberto, or is it again across the board?
Basically, it's younger population, but they are mainly from Northern Africa. Let's say that we got patients, Egyptians and Morocco. Those were younger than our previous patients.
Yeah. Well, at least you're not getting people from the United States invading. So, all right. Hey, speaking of which, the place that got invaded early on in our country was New York City. Glenn Aceda is the medical director for New York. Can you tell us what's latest in New York City, Glenn? Hey, Glenn, are you there? There you go. I think he's coming on. Glenn, you there? Looks like there you go.
Okay, sorry, the mute button was going back and forth. Hi, everybody. How are you? I hope everyone's well. We're still going, we're trucking along pretty well. Our volumes are still low, and when I thought about it, in the summer, you know, our 4,200 volume can actually go up to 5,000, 4,800, 5,000. So the fact that from the 4,200 number, we're still 10% below, actually is probably below even more, because it's not surprising. You know, right now we're going through a heat wave, that we would be hitting 5,000 calls per day, which we just have not. We're still under 4,000. Still about 38. I think yesterday was 3,900. The thing that we're still having is, as other major cities, is the shootings. People are getting shot. You know, last week we had a 1-year-old that was sitting in a stroller outside a park in a barbecue, was shot and killed. So it's just been horrendous in that regard. But as far as the COVID and other things, it's just kind of, you know, equalized so far, and nothing else really to report from here.
Hopefully Con Ed will hang in there and do okay, and no rolling blackouts for you, right? So,
yeah, you know, the brownouts and the transformer explosions, I mean, that's just coming. We know it.
I know, that's what I figured. All right, well, good. Thanks for the report. Let's talk about the other place that got hit early on, was New Orleans. So I suspect someone like Meg Marino might be on the line with us. Are you still there, Maggie? Let me see if I can find her. She was anyway, so I don't know if she's gone off. Oh, maybe not. Maybe we've lost her. Maggie, you there? Okay, and since we can't get her right away, let's move on to Erica Carney. We haven't heard from you for a little while in Kansas City. What's the latest there?
Hey, I've got a shift going on. We don't have the yelling like Chris does. If you hear any background, that's what's going on. Our numbers, so last week we hit for Corona a record high of total number of deaths in a day, total number of admissions in a day. We just were working with the city managers right before this call on schools and schools opening. I know that that's going to be a topic that you all have discussed or already discussed.
So bring it up. We'd like to hear
it. We've
ahead.
Decided that we're just going to wait until after Labor Day, and then we're going to do a staggered approach. So children, my child's age, 3 through 6, we're going to try to get them back in the classroom a little bit sooner than somebody like a high school or junior high student who can be a little bit more autonomous and virtual. So we have a lot of politics surrounding that, a lot of pushback when it comes to the school boards and city managers and getting all of our counties on the same page, but it's a start for the discussion. And then in regards to our trauma, it continues to be higher this year than it was last year. Again, unknown if this is related to anything else that's discussed. It's penetrating and blunt, and our level 1 trauma centers continue to be full. But there's high turnover with the trauma patients versus the corona patients.
All right. I think this has pushed me more and more into saying, let's do a quick survey inventory of what we can find, because it should be easy to pull up by charts. I hope for that for most of you, if not everybody, majority of you. So I think that'll be worth looking at. How old is your child, Erica, now?
He just turned 4.
Okay, so how do you feel about that? What's your feeling about it? I'm just curious. So you don't have,
Yeah.
you don't have to tell me. I'm just curious,
Yeah. I'm not quite sure. I think that the coronavirus in general is, I see the numbers, I see them continuing to increase, but I also see the issue of daycare and trying to find babysitters. For instance, if my son has to be home. And so it's definitely a tough job that our politicians have right now, and they are looking for any type of leadership or direction from the medical community. So the majority of my morning was just saying to all of the mayors and city managers, thank you for some type of message. This is a good start to say after Labor Day, and we'll continue to open up this discussion and just revisit it as the numbers continue to come in. So.
Yeah, and the main concern, of course, is that the kids they may get sick and may get something, but that the majority of them may spread it to the rest of the staff and the teachers, and then where are you?
Precisely.
So,
yeah. And our schools here in the inner city, I'm sure, just like every inner city, don't have the same resources in regards to money and support. So when it comes to PPE and quarantining, it's definitely a hot topic here.
Yeah. So let me ask you this. How do you like being a medical director for EMS system during a crisis, right? Welcome to the club now, right?
Yeah, thank you. Thank you for the warm welcome.
Yeah, that's great. Hey, let's go ahead to Meg Marino. I think she is back. She had to get off for a second. Meg, you there from New Orleans?
Yes. Hello. Thank you so much. Sorry, I missed you a few minutes ago. I had an urgent call that I had to take.
No problem.
Thank you guys so much for all of your help and support. We have been having a hard time in New Orleans recently. We had we had a recent suicide among our EMS community this week, which was really heartbreaking. And we've had a lot of employees who've been suffering with mental health issues, and we've been trying to find ways to support our employees and support each other. So we've really been focusing on bringing counselors in to try to talk to people and just checking in with people constantly. We've had a big uptick in the number of employees who are out sick with COVID symptoms, and a big uptick in the number of positive employees. So we had 7 positive employees in 7 days. Which was more than we've had even in April, when things were really ramping up, and citywide we've had more we've had more COVID positive people in our community. So every day we've been getting a few more people testing positive. So I think we had 3,100 yesterday and the day before test positive for COVID just in Orleans Parish. And that those are larger daily increases than we saw even in April. So we definitely are seeing large increases, and we're trying to do everything that we can to be ready for this next surge in the setting of decreasing staff. So just trying to do everything that we can to support everyone.
Meg, I'm going to make a suggestion, which is there's a 2-part series, I think, that's coming out that Lauren Maloney has been sort of spearheading on the whole issue about mental well-being and crisis coping. and wouldn't be a bad idea. It's going to be co-authored with Chris Colwell, that's on the line here, and Sandy Schneider, you know, from before, and may run it by you just to see if there's anything else we add, or if you think it's a good, you know, a good start, etc. And this first part is just framing the issue, and you sort of said a lot of it just now. So we'll talk a little bit about that. You know,
Thank you.
yeah, so that's great. So remind me about that later if you haven't heard from me. Okay, so we'll get you plugged in there. Okay, good. Hey, Justin, if you don't mind, can I jump ahead and bring up the issue that you wanted out of Cincinnati, Dustin Calhoun?
Oh, that would be great, sir. Sorry about that. I really apologize if I got called. I got called by our CMO and had to step away from my computer.
Hey, we're really pleased that so many people can make it to the call. It's because you're all very busy. So go ahead.
Great call. So this is a question that has just become a little bit of a, not heated, but it's getting there. We have these elastomeric full face masks that have P100 filters. That's what we're using as our N95 or higher equivalent. It's great protection. They're hot in the summer. They're not super comfortable. They're great because there's no resource cost to them. We already have them. We're already fit tested to them. So we're not burning through disposable face mask filters and masks. But the fire department really wants to push back to just the bare bones CDC recs of using N95s or higher, which would be our masks, only for aerosol generating procedures or high risk patients, rather than just using them for every patient that we see, which is what we're doing now. I really want to push continuing with this N95 or higher protection all the time, but I kind of wanted to see what others are doing and if I'm just nuts or over conservative here, and should just sort of back down on the issue.
Okay, got it.
Hey, Dr. Pepe, it's Erica. Do you mind if I ask a question of Dustin real quick? Hey, Dustin, we've got a huge fire department here with huge union input. Our issue is we will recommend a mask, but we're not having great compliance with the recommendations. Are you having good compliance with the N95 or higher?
We are. We're having pretty decent compliance. One, because it's really easy to see whether they're using it or not because it's this big face mask. So I can kind of spot check that in the ED. And our union is actually fairly in support of it because we have a very active safety committee. So anytime I say, well, this is safer, I pretty much get their backing immediately, regardless of what it is. So that's the advantages I've got.
Thank you so much.
Okay, got it. Anybody else have any comments or reaction to that, or maybe we could put it out also as a query to the Eagles? That I don't think we have anything hot and heavy right now going on. We probably could put that out. Anybody have any answers or questions for him?
Dustin, John Jew, we're probably the other large area using elastomeric masks. We've had elastomeric masks since the start as well. There's about 3 comments we have. The first one is that in long term, in other words, if I wear a N95 mask, it's very uncomfortable, but I think elastomerics, when you wear them for a long period of time, it's much more comfortable than a N95. The second one is you take it on and off. The N95 becomes essentially reused mask here as well, and you lose your protection from your N95 mask. And then the third one is the airborne controversy here as well, the difference between P100 and N95. And obviously the P100, providing both are fit correctly, gives you better protection against airborne mask as well as intubation. So so there is a continued debate about that, but we're sticking with elastomeric no matter what.
Hey, John, I want to then just really reemphasize something you just said. So let's say I'm wearing an N95 right now, going in to see a patient and go back to the emergency department, and then I come out and I have it with me still, but I take it off, and now I go into a grocery store. Have I lost my protection there?
Yeah, you do. In other words, I think it depends upon if you're close to another person here as well. Taking an N95 off and on is much more problematic than putting an elastomeric off and on. Personally, I do both, but it's much more easier to flip the elastomeric mask and just tighten it up, and it's much more adjustable. So you can wear an elastomeric mask much more carefully than a reused N95.
Okay, got it. Thanks. That's why I want to make sure we had that sort of specific thing clarified and emphasized, because I don't think everybody knows that. Okay. Hey, Remley, what were you saying on your ESO data about the use out there with the N95s?
Yeah, so we track N95 use and reuse as part of the national data set that we publish on the website every morning. And we're still showing about half of all uses are actually classified as reuse.
Okay, thank you so much. Hey, then, Tom, I'm going to come up to you, maybe then just give some reaction out of there, out of Cleveland. You're saying that you still have N95 for all care, right?
Yeah, that's right. And the crews have been, I'd say, fairly compliant with that. Where we struggle with is having them wear masks when they're not doing patient care and around the station. The longitudinal study we did that we submitted to PEC, in the time period of 3 weeks, we surveyed about 260 EMTs and medics, and none of them had conversion to a positive test during that time. So at least the N95 is working well for us right now, and our supply right now is good.
Okay, cool. All right. Anybody else had something to say to that? Or before I move on, I'm going to hit somebody else up here in a second. So I thought maybe it's about time I pick on our church elder there. You know who that is, Ray, right? Ray Fowler from What's Happening in Dallas. You there, Ray? Saw you were on. It looked like Ray was on. Maybe he's also distracted by something else going on. Ray, are you there? Ray Fowler. So, okay, we'll see if he comes on in a second.
Unmute audio. I'm sorry,
yeah.
I have trouble with the English language. How you doing?
You're struggling with it, right? It's great to hear.
Yeah.
I'm doing good. Thanks for the great birthday wish, by the way. That was very nice. So good to see you, man.
Well, at your age, Paul, we have a phrase, it's better to be seen than viewed.
Very good.
He looks so natural.
Okay, Ray. So what's happening in Dallas? Do you look pretty ready for bear, loaded for bear there?
Well, from the front line here, just having worked all weekend in Parkland, it seems like the number of COVID cases I'm seeing just from a Gestalt is a bit less.
Okay, hope so.
That's just my own personal experience. Mask wearing clearly works. Of interest, Paul, my own COVID test went positive, and the story on that, this was that I have no symptoms. I'm fine. I mean, knock on wood, but we're doing a scientific study where we have 40 of our faculty being tested, and I heard that my test from July 3rd was positive.
Okay.
That was nasal.
So you're
where they do a brain biopsy.
The brain biopsy, yeah.
And but the serology is negative, so I'm being tested again today. So,
are you a super spreader then? You think?
You know, I think there's an association between picking your nose and being a super spreader, Paul. So you ought to know. Just kidding.
Yeah.
So anyway,
I'm glad you're well, though. That's fantastic. Then good.
Well, I'm 67. You know, I'm the kind of guy that you kind of worry about, but it sort of brings a new meaning to frontline. But in any case, it's rocking along. The regional case presentation rate is identical to last week. It's neither higher nor lower. Excuse me. The ICU admission rate and folks on vent that are COVID is the same. It's neither higher nor lower. So, you know, we're just sort of living the dream down here. I wish everybody would wear a mask.
Yeah. So how about, do you know anything about the results on the rest of the faculty? Has that been also high, or are you just—
To my knowledge, every other faculty member, to my knowledge, is, I hesitate. I think we have 110 faculty. I think one of them, I saw a posting that one of them had to ditch their shifts. So I think we may have one faculty that's actually positive and symptomatic. I know of 2 residents out of 66 that were positive.
All right. So
which is an exceptionally low thing if you figure that we're surrounded by COVID. I know that last Saturday, 40% of the patients I saw had COVID.
Yeah. So I think that that sounds good then. That is a low attack rate and all that. But I think your issue probably you didn't get the hospitals because you're always running around with all those young people. That's what it is, right? So
well, I'm taking zinc and melatonin and vitamin C and vitamin D and Pepsid. These are all published.
Yeah.
And you can look these all up. To have cytokine storm inhibition, and so on and so on. And so one of the infectious disease guys told me early on, take a zinc supplement every day because that blocks the stimulation of NF-kappa B, which goes on to stimulate IL-6. And so it may be a supplement reason why I didn't get sick if it was not a false positive. It may be.
Yeah, right. That's actually a good point. So they're going to continue to follow you. Have you had any further PCR tests, or is that?
I'm having it today.
Okay, got it. Okay, good. Well, good luck with that. I'm just glad you're not ill. So that's fantastic then.
In the news today, there was an article about COVID virus being found in donated blood from a patient who had been sick a month prior.
Okay.
So that, for those of us around in the 80s when HIV showed up, and then we heard that the blood pool, the donated blood pool, was becoming contaminated, that brings new meaning 40 years later, doesn't it, Paul?
Yeah. Oh, yeah, absolutely. And I remember it very well. And not only the psychological impact, that it had for everybody up there, and the sociological implications was just fascinating. So, but still, in terms of the blood supply, that brings up an interesting issue, especially since blood donations are down around the world at this point in time because people are staying in. Okay, so let's hit some other cities. Joe, thank you, Ray. Anything else you can think of? Okay, good. Joe Holly, why don't we pick on you for a little bit in Memphis? Anything new to report there?
Hi, Paul. Good morning, everybody. We're about where we have been. Our numbers continue to rise fairly steadily. Actually, our R-naught yesterday was 1.13, if I remember correctly. So we're growing fairly substantially. EMS and the emergency departments are under pretty significant strain at the moment. Looking at our mathematical modeling, which we reran last week, we show that we are about 1/3 of the way to our predicted maximum hospitalizations, ICU utilization, et cetera. So we have a lot more ahead of us than we do behind us at this point.
That's too bad. I'm sorry to hear, but it's sort of tracking what we're seeing in other places. The other place that may be picking up now is Hawaii. Let's go out to Honolulu. Libby, what's happening there?
Hi, Paul. Good morning, everybody. So far, so good. We had a little bit of a bump. We were up to about 40 cases a day. We're kind of back hanging about 20s, really pushing the contact tracing since we're having a hard time getting timely testing done. Big issue here is opening schools. We managed to stave off reopening for tourism for another month, which doesn't mean we're not getting tourists. We're just getting the lousy variety that have no intention of staying in quarantine for 14 days. But we're not going to encourage travel until September 1st, but working on the schools right now.
Okay, thanks. Then let's, if you can, give me I think Erica, you and some of the others can give us a follow-up maybe next week or the week after so we can see, because that's a big issue for all of us. I think we only have a couple of minutes left, but I'd like to still capture some of the people that are out there. Terry Valenzuela, what's happening in Tucson? I know Phoenix is getting hit hard, so what about you guys down there in the southern neck of the woods? Terry, can you hear me okay? Maybe just trying to unmute. Terry Valenzuela, just in case you're TV, are you there? Okay, if not, let me move on then to RJ Frescone in the northern climes of St. Paul, Minnesota. What's happening in St. Paul there?
Still pretty stable, slight rise. I think we're at 4% positivity rate right now, but we're hanging in there. The reason I attend these calls, Paul, is to find out all the disasters in the rest of the country.
So you could feel better psychologically.
We've just been boring up here.
Yeah. Okay. Well, that's great to hear then. I'm happy for you. Anything else to report or anything new from your end in general?
No.
Okay, good. All right. Terry Valenzuela, by any chance, are you on yet? I don't know if you've heard me or not. If not, we'll just have to bypass that one. And then we've talked to pretty much anybody I've missed. I apologize if so. John, Jew, before I do, I think, Crawford Beecham. How about Philadelphia? Want to go ahead and get on with us, Crawford?
Things continue to be quiet here. Numbers are going down, middle of the heat wave, and shootings continue, and our opioid crisis continues. So that's about it.
Okay, I'm going to see if I can get some of the documentation on how much the opioid issue has become part of it, and particularly if it has anything to do with dead on scenes or cardiac arrest. But I think it's on increase, but it doesn't account for all the stuff we were seeing in our study. Okay, I'm trying to see if there's anybody from the group that I've missed here. I'm trying to go through, and I apologize if I have. Anybody want to say anything? Craig Manifold, anything you want to tell us about what's happening in San Antonio area?
No major updates. We're at a point where we've hit maybe a little bit of a plateau, and we're trying to determine, is it a matter of July 4th holidays, or do we still have a little bit more of a time frame to be concerned about that? We are at at really what we consider a healthcare capacity issue. We haven't had to open up extra facilities just yet, but we are using and maximizing our brick and mortar facilities, and actually sending some of our physicians to our areas south of us on the border who've been hit a little bit harder, and helping out with their work. One national component I'd bring to your attention of EMS medical directors that will be a discussion over the next few weeks and months is changes in pre-hospital education. If you're following some of the changes through CAPC and the registry, that it's currently, there's been some leeway given for people to be able to complete their requirements without necessarily having any assessment completed with their works, and or again, competency-based processes where people can go in and take an assessment, and that's it. There's no other studying or materials that need to be reviewed and things like that. So pluses and minuses with all those issues. And as EMS medical directors, I just encourage you to be aware of that and engage in the discussion so that we don't get into a process where that's a long-term solution for us as well. So thank you.
Hey, Angus, you led the group today with the Florida medical directors. I think they're on with you. I don't know if there's any further questions from them, but can you tell us anything to report on from not only from the Tampa Bay area, but also from Florida as a whole? We've heard a lot from Ken already, so I think we probably covered the majority of it. But anything new from you?
Sure, Paul. Yeah, we've still got a couple dozen people listening in from Florida. Florida remains one of those states that Ken talked about. We're still seeing, at least in my area, the most number of people in an ICU and the most number of people vented that we've had so far. I think I've got 100 in the ICU and 60 of them are on vents as of today. We're seeing significant mortality, although most of that mortality is 75 or greater. We have a ton of skilled nursing facilities down here, and we have hundreds and hundreds and hundreds of positive patients out in our facilities.
Okay, got it. Hey, John Chu, I always like to give you the last word, as they say. Anything new to report from the world of infectious disease in particular?
Yeah, there are actually.
Yeah, also, a little about Portland because of the civil issues going on there.
Yeah.
But, what else? Let's start with the infectious disease reports.
The infectious disease, the only real comment is that the CDC in Emerging Infections published a study from Korea about children and their infectivity and transmission. It was in emerging infectious. And the bottom line was that they found that children, when we lump them all together, under the age of 9, they did not transmit the virus a lot in schools. Over the age of 10 years and older, they transmitted just as well or even better than adults. So I think we need to look at preschool, probably hardly any transmission, but you have to be careful. This was done in Korea and was not done in the United States, where Koreans use masks, etc. The other one is that there's a continued, I would say, examination of repeated positivity of the RT-PCR tests. And Ken Sheffy and I have been emailing and texting each other. And the bottom line is that there's increasing data that CDC, as everybody knows, came out with revised recommendations of not testing again. That I think it's 8 or 10 days after the onset of symptoms, you're probably okay. But there is limited data, but the data I'm seeing right now is that it's very unusual for a person to remain positive. I'm just making it after 8 days. And Woeful actually published this about 3 months ago, and there's more literature coming out from that. So we're going to see a much better understanding of if it's still infectious or we're finding particles here as well. That's it from the infectious disease.
Okay, anything report in Portland, particularly with the let's say, the political issues going on there with.
Yeah, we're stuck in the middle of civil disturbance here, but frankly, I think we're trying to cope with it as well. I think it's not helpful. We're actually losing our reagents. In other words, all our hospitals as well as our testing, because of the outbreak in southern United States, we're starting to see limitations in our ability to test as well.
Okay, John. Well, listen, thank you so much. And then I particularly want to give a particular thanks to both Marty Schreiber and John Holcomb for their input and hanging with us today. And just was fantastic discussion. It's really great. And congratulations to both of them for the successes they've been achieved on behalf of our patients and giving us leadership here at, in the world of EMS. So thank you so much for you guys for that. And with that, I think it's, we were a little bit over time from what I usually try to run. So we want to, again, welcome back my friends to the show that never ends. And John, let's do an earlier report on infectious disease next Tuesday. I'll try to remind me of that and we'll come up with a plan. That'd be really terrific. Okay.
Okay.
Okay. So thank you very much. Any final words from you, Craig Manifold? You want to sign off?
Well, as always, thanks to everyone for joining in, and great discussion on TXA that hopefully we can all go back to our partners in our local trauma services and be able to share that information and convince them that that's a pre-hospital intervention that has some merit. And with that, we appreciate you sharing a little bit of your time and talents, and that's all we've got for today. Thank you very much. Appreciate it,
All
Paul.
right.
Thank you.
Okay, thank you. Okay, bye-bye.
Thanks, Paul.